Thank you, guys. And obviously, just in interest of time, I'm going to be moving ahead with introducing the first speaker and obviously ask the panelists to come up on stage. The first speaker for the next session, which is the ISRS session, is going to be none other than David Chang, who's going to be talking to us about capsular complications. So David, I'm sorry that we are late, but I know you have things to go to, and we'll start quickly. Let's go. As soon as you can.
All right, well, thank you very much. So I'm going to talk about the problem of premium lenses with capsule tears. So may I start? Anytime, if you could, okay, great. And I'm going to do this by showing 7 cases. These are my relevant disclosures. So this is kind of a unique problem, because even if you rupture the capsule but prevent vitreous prolapse, you put a 3-piece in the sulcus, get a 20/20 result, this is a bad result for many patients because they decided they wanted a premium lens. And they will have trouble for the rest of their life accepting that they never got that lens. It's worse if you already put in an EDOF or a trifocal in the other eye that they're happy with. And so they could be very, very unhappy, and you can refer them, and there's not much we can do about it at that point to go back and try to put that lens in. So I'm going to say something a little controversial, and that is I think this is where we can be more aggressive than usual if you think there's a reasonable chance of putting that principal lens in. So here's 2 situations where I'm putting in a trifocal, it's a panoptics with a single radial anterior capsular tear. There's no wraparound. In the left-hand side, it's easy because it's a spherical one, and I can have the haptics 90 degrees away from the tear. In the bottom one, though, the toric axis is right where the anterior capsule tear is, but because it hasn't wrapped around, you actually have a fornix there, and because the haptic is going to unroll and unfold slowly, you can get this aligned. All right, well, this next one is tougher because it's a high-power monofocal toric. I can see debris and Berger space, and it's a posterior polar cataract. I stabilize, come out, you can even see the posterior polar opacity next to the break. But it's a high-power toric, and I'm going to need to rotate it because a T5 has to be on the right axis. So I'm going to try to grab the opacity and try to round that off, because if I can convert to a posterior CCC, and there you can just follow it right over here, and it's very thin. So my favorite forceps, this is the Seibel capsule forceps from MST. And what's beautiful about this, I can come through a side port. I don't have to go through the main incision where I would burp out viscoelastic shallow of the chamber. I might have vitreous prolapse. And I just keep putting plenty of viscoelastic in there. We don't have to aggressively remove it. And now with that T5, as long as I get the haptic in between the anterior posterior capsule, now I know I can rotate it and not have that tear extend, because obviously it does no good to put this in and have it be in the wrong axis. That's a zepto capsulotomy, but now you can see the posterior CCC. So there's an example of posterior CCC. Now here, there's a rent on the temporal side, and I can't convert it, but there's vitreous prolapse to the incision. So the pearl here is I have to go through the pars plana, because if I go through and do the anterior vitrectomy from the limbus, this is just sweeping the incisional area, I run the risk of expanding that rent so that I don't have much posterior capsule left. Now the other eye has a high-power toric, as you can see from the topographies. This eye is scheduled for a T6. I can't get away with LRIs. And so even though the rent is where the haptic has to go, because it didn't extend, and I'm going to see what happens. The worst thing is if it decenters, I could just take it out right now and put in another lens, put in a monofocal. But here I have to have it lined up so that haptic is sitting over there, but there's enough support that this lens remains stable for well over a year of follow-up. All right, now this is a little tougher. This is a woman wanted a Panoptix with a T3. This is a wraparound tear. So I get that last piece out, and there's so far no vitreous presenting. So I'm going to do a dry aspiration of some cortex. The wraparound is on the temporal side. It's wrapped around, and that's why I have in the horizontal axis this big tear. Now, this is not something I'd normally be that aggressive about, but this woman really hated glasses, really wanted a bilateral, multifocal, and if I can't get this, I don't know what I'll do with the other eye. So let's give it a try. So there's no vitreous prolapse, so that's helpful because now I have some support, the hyaloid, and I have to get each haptic in there. It's a toric with the rule of astigmatism. So even though the posterior capsule has the rent in the middle, the anterior capsule has a wraparound, it's going to work out. Now, it might not have it. This might decenter, in which case I go back, I take it out and put in a three-piece in the sulcus, maybe a light adjustable lens possibly with consent now. But my point is, if you think there's a chance it would work and the patient really wants it, you know your patient, and I put myself in their situation, why not take a shot at it even though you're not sure it's going to last? This is a case with a posterior polar cataract, again, expecting a Panoptix toric. We did talk about the fact that it might not work. There was a big rent in the posterior capsule, right where the posterior polar cataract was. So we do all the cleanup, and at the end we still have a rhexis intact, but half the posterior capsule's gone. Similar situation. Knowing the patient, I think she's going to be okay with me trying, and you have to tell the patient afterwards, in case something went wrong, I thought about what I would want if I were in your situation. So this is reverse optic capture. I've done a vitrectomy, the lens is in the sulcus, and then each haptic, one at a time, has to be dropped into what would normally be the capsular bag. So each haptic is under the rhexis, but the optic lies anterior to the rhexis. And if you've done reverse optic capture before, you'll know you get sort of a rectangular opening. The axis is at about 165, 170. So there you see where the marks are. The digital alignment doesn't show up on this video. And fortunately, it's going to center well because the rhexis is centered. And I've got the toric axis aligned. And again, if it doesn't work out, I can go back and take it out later. Finally, a case where I was going to have a toric vivity, and this is another wraparound. And you will someday have, but we now have the light adjustable lens in the United States. And this is a wonderful option because it's a three-piece lens and it's a custom toric lens. And it has the LAO plus has some extra convexity on the surface, so it acts like an eat-off lens. And so this is a situation where I can't remember if the patient was all right, that I could talk to her on the table. This is sometimes the problem with the consent. But what I'm doing here, if we can just clear that, it's almost over. If we can, we've got the lens centered in the sulcus, and the rent is to my right, so I'm putting the haptics 90 degrees away. I tuck the optic under the remaining edge, and that lens is centered, and we can now go back and adjust it and create a custom toric. So the pearls are ACC tear, you can be quite aggressive. Posterior CCC can really bail us out. Think about a posterior pars plana anterior vitrectomy, so you don't expand these tears. Reverse optic capture, really good, and we can have this additional option of the LAL. All right, thank you very much.
Thank you, David. And while Doug Koch, who's going to go next, while he's setting up, I just have one question, I think, and I'll obviously take audience if they need to. But one question to you is there a size of an intraocular lens before you do the reverse of the capsular rhexis, before you do the reverse optic?
So reverse optic capture, you'd like it, certainly a little bit smaller than the optic. So 5.5 works. I've done it where sometimes they have to enlarge the rexus just a little bit to be able to do that. And of course, it has to be centered. So if it's off center, the converse is if it's too large, it's just not going to stay.
Awesome.
And sometimes you'll try it and you can't get it to stay. You have to take it out.
And I'm sure the audience might have one question. If they do, it'll be the right time to ask David because he has to go for another session.
Another session. Yeah.
Okay, awesome. Thank you so
good.
much,
Thank you.
David. Doug, over to you. Thank you so much for being here. And this is one topic that really baffles all of us till date. So IOL power calculation. Go for it.
Thanks, Ashvin. That's an interesting topic you gave me. And I had to think about this for a minute. What would be unique about this? So, I mean, the bottom line with these premium IOLs is we have to be within a half diopter of target, ideally. This was shown in a paper by Hayashi, where induction of a half diopter of astigmatism or the Restore 3 diopter dropped the distance vision by almost a line and a half. So, what do we do? Some of this is obvious. Get 2, preferably even 3 measurements. Here's a patient who's got 2.48 diopters of astigmatism that you can see there, but he's got an abnormal mire and with an irregular LED reflection. The lens star for this patient gave a much different value, and what I did is remeasure this patient, treated the surface, and got 2 measurements that were the same, and then we knew that we're in good shape. Really critical, obviously, for your premium IOLs. So we like to measure 3 times and at least on 2 different days. And we use different devices. We use 2 biometers, and we use a tomographer topography device, the Galilei. So I also have the advantage of seeing placido mires, and it makes a big difference in the repeatability and the accuracy of our measurements. And you really have to verify the quality of your measurements. Obviously, optimizing the ocular surface is important. We ask all of our patients before we measure them to use tears, warm compresses, and lid scrubs, and that's really helped our accuracy as well. You want to not miss subtle corneal pathology, and it is easy. Some of it's going to be obvious, EBMD or Salzmann's, but here's a patient who had a trifocal, complained of poor quality of vision, and you can see he only corrects to 20/50. And you can see the topography is kind of funny looking there. And then if you look at the mires, which is again why I like having a placido image, you can see the irregular mires below. And this patient had a very subtle subepithelial scar that was distorting the vision. And I did an IOL exchange and put in an IOL that was a monofocal with 0 spherical aberration and was able to get his vision to 20/25. Use the latest formulas. There are a lot of formulas using geometric optics, ray tracing, artificial intelligence, hybrid formulas, although really almost all of our formulas now have some element of big data, maybe even artificial intelligence, but they're good formula. The newer formulas are clearly superior. So use the newest formulas. And what are they? Well, they're highlighted here: the Barrett, the Kastrop, Cook, Holiday, the 2 ray tracing, the Hill RBF, and several of the hybrids. Now, you're not going to use every one of them, but pick 2, or at least 1, or maybe 2, and use those in your patients. Well, what kind of accuracy can we really expect to get? If you look at what we've published and others, the patients really fall into 2 categories: normal eyes and long eyes. I think you can hit 90% within a half diopter of target. But short eyes and post-refractive, you're looking at 70%, and that's something you really have to share with your patients. One other thing, don't overcorrect with the rule of astigmatism, and don't undercorrect against the rule of astigmatism. Look at your toric calculation, even if you're not thinking you really need a toric lens. So here's a patient, this is using Veracity. This is not a multifocal, but it makes the point about astigmatism. He wanted mini monovision, some intermediate. You can see his K readings. He's got about 0.3 at 0.4 at 30 degrees, and you think, this guy doesn't need a toric. And then you kind of look at what the predicted refraction is, and it's 0.68 diopters at 10 degrees. So that's actually not acceptable. So if you look at what happens when you program in a toric, a 1 diopter toric, this would leave the patient with 0.3 diopters at 100 degrees. So that's what I did. And he ended up with a half diopter at 75, which is nice because what's going to happen? That's going to degrade or diminish over time as it goes against the rule. And the final point I want to make is, know what the defocus curve is of your IOL, of your premium IOL, and use it to your advantage. For example, here's the defocus curve for the Synergy lens. It's a very steep peak, and these patients do better actually if you target a little bit on the plus side, maybe a quarter diopter hyperopic, because a quarter diopter hyperopic in your lane is actually plano at distance. So that's the lens you, and same with the Panoptics, we found that you really want to target a little bit on the plus side. On the other hand, there are IOLs that have a larger landing zone. This is the Odyssey lens. And if you target, because it has such a big landing zone, if you target minus 0.3 diopters, you're going to get better near vision and yet still get 20/20 distance vision. So, in summary, get lots of measurements, preferably on different days. Don't miss pathology, even though it might be subtle. And despite your best efforts, you're going to obviously expect to have misses. They're going to require corneal refractive surgery or lens exchange. Thanks very much.
Doc, excellent talk as always. Now we know you are the IOL calculation guru, so I will take advantage of this to ask you a few questions, if you don't mind. First of all, what I'm always puzzled with when I do the toric IOL and I put in different formulas, I get most of the time different axes where to put my toric alignment in. So I want you to comment on that, and what is the influence of surgically induced astigmatism on those calculations, and do you need to put it into your formulas, the surgically induced astigmatism? Because when you work on a temporal side, you induce like 0.08 to 0.12 diopters of astigmatism, and in those low diopter, low astigmatism corrections, it can mess up your calculations. So I would love your input or insights on that.
Great questions. You know, with Veracity, we have three formulas: the Abulafia Koch, the Barrett, and the Kane, and they're very close to one another. They're remarkably uniform, so that makes my life easy. They rarely vary by more than 2 or 3 diopters, degrees rather, and very rarely do they vary in the power. So I just rely on those. Those are the ones I'm used to. As far as SIA, surgically induced astigmatism, I think you're right. It's going to be about 0.1 or less. And yes, it'll affect things when you're correcting small amounts of astigmatism. But you know, I kind of try to almost factor it out and ignore it and rely on the formula. But the formulas that I have are programmed with my 0.1 diopter, so that helps me. I think one of the things you see when you start to look at this more, for example, that patient who had astigmatism at like 30 degrees, it said to put the toric at 10. And that's because the formulas have accounted for the fact there's some tilt and other factors that fit into it. So there's this kind of conundrum about, well, the cornea is here, but it's telling me to put the IOL there. We've learned to trust the formulas.
Thank you.
All right, thank you.
Doug has to go, so if anybody has a question, you can ask him. But thank you.
So I have the proud privilege of introducing none other than Chiu Soon Fake, for whom India is her second home, number one. And whatever publication you are trying to publish, you find that she has already done work. So that is something which is so motivating to see her around. So over to Chief to put across suturing the bag in subluxated lenses.
So thank you very much for inviting me. And what suture material do we use when we want to suture the lens? So we know that polypropylene actually biodegrades 5 to 10 years after it's used. 9.0, it may not last because there have been reports that it's broken even at 6 years. And what I prefer to use today really is Gore-Tex suture. This is actually 7.0 caliber. It's off-label use for scleral fixation, but it's got excellent longevity. We can use polypropylene 6.0 for the Canberra flange. So a lot of people have seen this technique but do not really understand. So let me just give you my concepts for how to actually use Gore-Tex suture without using the needle, which is really short and thick and not meant for ophthalmic use. So if you have a CTS that's already loaded with a Gore-Tex suture, how do you bring it to the fixation point at the sclera? So if I had a needle that's already loaded with a suture and I extend a loop to act like a lasso, I can easily feed the end in for the suture, and by pulling it, you can see how we can lasso it to the scleral fixation point. So this is threading it in to the needle, and what's important is, as you can see here, you must have everything dry. You must grasp with your fingers, not the forceps, because it will flatten that suture, and you will not be able to thread it in. And you cut it on a slant so that it goes in easily through a 27 gauge needle. Now when you enter at the sclera, I like to go 90 degrees perpendicularly so I know exactly where I enter. You want to go actually horizontally. Once you've entered, push down on the capsule if you're doing a fixation with a CTS there, and then pull back the needle to free a loop, and that actually helps you to get your Coughlin hook. You see, I pull back and then there's a little loop there, and your Coughlin hook can easily pull that out. Okay, so that's how you use this device, which is very cheap. Okay, so let's have a look at some cases. This lady had a fall, and you will soon see that actually this lens is decentered, and it's actually a Restore +3, and she wanted to keep that, obviously, because a fellow eye had a similar lens, and I'm just creating a Hoffman pocket where I felt that the lens was most decentered, and there was the best axis to actually place the suture to reposition this lens. So one loop of one suture is through the back complex, and the other goes above. All right, you can do it one in front of the other, and I usually fixate about 2 mm posterior to the limbus. So it's gone through a Hoffman pocket, and the pocket needs to be at least half scleral thickness, and we're now hooking out the suture from the pocket, and then you throw a 2-1-1 knot. When you're doing a 1-point fixation, you need to tie a little tighter because the knot actually will fall back into the pocket, and you will have a slight decentration if you titrated it inappropriately. But you'll see that this patient had a very well-centered lens after that. Now this is a patient where you can see now the lens is dangling. Yes, it's a CTR with a toric lens. Okay, so I've marked the toric axis already, and after doing vitrectomy, you can see this was almost floating in the vitreous cavity. Clear all the vitreous, very important. Triamcinolone that's diluted. I usually use about 30% dilution. That helps to ensure a complete removal. And then, having created the Hoffman pockets in that axis where her toric axis is, I come through the capsular bag from posteriorly and then draw the suture through. And now this other suture goes above. All right, so you have a belt loop around this complex. You don't tighten on it, and you just do hand over hand transfer to the other side where you can see the toric alignment marks, and that's how I want to get this well centered, all right, matching those marks with my axis. So you do the same for the other side, and then this one goes above the complex. So this is really quite minimally invasive, just 2 pericenteses and 2 Hoffman pockets, all right? Make sure you have no vitreous there, and then retrieve your sutures. You don't tie it yet until you've centered the IOL, so it's a 2 and not a 3-1-1. You don't tighten down because when you do on both sides, you don't really need it taut, all right? You just need it symmetrical so that when you put it back there, you can have perfect alignment of axis and a vision is restored. So you can do a similar technique with Cana Brava, but in this case, you don't need a knot. So this is a patient with a single piece IOL that actually dropped to the back of the eye, and my retinal colleague actually brought it up. And you can see it's a similar concept of a belt loop suture, but the way we do it is first to just use the needle and then thread the suture. And actually, I can thread it in my fingers. I can direct it more easily from externally. I just thread it through. You can see my fingers doing the work. And you do it for the other side as well, all right, through the capsular bag complex, just at the angle there so that you're symmetrical. And just use your fingers and thread this segment of 6O polypropylene suture. I always flange it in case I accidentally pull it out. So in this case, there's no Hoffman pocket. It's going through the conjunctiva and sclera, full thickness, and I just do one in front of the other around the 2 mm point posteriorly, and then clear vitreous, do a peripheral iridectomy, and then flange. But you need to make sure that the flanges are actually buried deep to the tenons. Okay, so just the last case, this is a patient that's complex, and sometimes we want to do minimal surgery. In a case like this, he's had 2 grafts, and this one is about to fail as well. A tube there, the iris is tattered and torn, and you can see that this lens is now dislocated. And in addition, it's a single piece PMMA. I don't really want to take it out through the cornea. Right, so what do we do? I want to do minimum. I want to make sure that his graft lasts, especially when he's the husband of an ophthalmologist. So, you know, she's going to check on him every day, count the cells every day. So this is a PMMA lens, okay? It's still actually 1 in the bag and 1 in the sulcus. So I managed to just take it out of the bag and rotate it in front of the rest of the capsular bag. And again, after having rotated to this axis so that I don't have to go to where the tube is, all right, I'm going to horizontally fix this. And again, it's just 1 in front and 1 behind that haptic through the bag. Okay, so you can do this with minimal invasion to the anterior chamber, just 2 pericentesis, and you will be able to do the entire surgery. And I'm just making sure, I'm so scared to retract the iris because it's really peripheral anterior synechia, and it's really tattered and it's sutured. So I'm just making sure that I've come through the right site. I can hold the lens with my bag, with the lens forceps, so that I can make sure that everything is in right position. And again, we're doing the same procedure, 1 behind the haptic, the other in front. And I think you've seen the rest of the surgery is just like the rest. We would just tie 2 on 1, center the IOL, and at the end you have a very good outcome. So just my summary slide now. Very important, clear vitreous when it presents. Plan the site of fixation before creating the Hoffman pockets. Half scleral thickness to cover the Gore-Tex knot to prevent exposure, erosion, and infection. Ensure polypropylene flanges are buried in the sclera views, the Canabrava technique, and you need an optimal tension on the suture to center the IOL. Thank you very much.
Thank you, Professor Chi. Just one question while Dr. Jodhbir kind of sets up his presentation. One question would be, when would you not do sutures, and what kind of cases would you avoid sutures in these cases?
I really think that sutures in this manner actually are very, very minimally invasive. If I don't even have conjunctiva to play with, right, sometimes it's all necrotic and so on, or it's scarred from previous surgery, then I would use Canabrava's technique so that you don't have to dissect anything at all. Yeah. Thank you.
Awesome. So next up we have Dr. Jodhbir. Thank you, Professor. We have next Dr. Jodhbir Mehta, who's going to talk to us about endothelial cell therapy for decompensated corneas.
Thank you, Ash. So I'd like to thank the organisers for the invitation to talk in this session. So I'm going to give you an update really on where we are endothelial cell therapy, which is a very hot and fascinating topic for decompensated corneas. So as most of you will be aware, there's been a massive change in the face of corneal transplantation performed around the world, with endothelial keratoplasty becoming the leading procedure. And you can see data from EBAA above in 2012 and in Singapore back from 2008, where it really overtook us, penetrating keratoplasty as the leading indication for endothelial replacement. And the reason why we basically all shifted to these lamellar surgical techniques is because, of course, we get better outcomes in the long term. And you can see this from this Kaplan-Meier survival curve on the right-hand side when you compare EK and anterior lamellar techniques compared to penetrating keratoplasty techniques over a 10-year time period. Now, the reason why there's been a lot of buzz and there's a lot of interest in basically endothelial-based surgical procedures with respect to cell therapy is because the cornea is the perfect model for basically cell-based therapy. Of course, we can change the epithelium and grow this out in the lab or grow this on the surface of the eye. Keratocyte cell therapy is still at preclinical stage. And of course, endothelial cell therapy now is coming into basically clinical trial situations, and I'll focus a lot of that in my talk. The other thing is that most of our patients have endothelial disease that we actually do routine corneal transplantation for. So the impact, of course, is going to be very high. When we think about endothelial replacements, there are really 2 groups that really push the limits with respect to cell culture. Professor Kenishida's group in Kyoto have really done an amazing job to basically get this all the way basically to clinical trials and approval for use now in Japan itself, and have really pioneered a technique of basically doing cell culture of endothelial cells, so expanding them in vitro. And they use a technique essentially where you use one media to basically proliferate the cells out so you have enough cells. Our technique in Singapore is slightly different, where basically we use a technique where we call it a proliferative conservative media, then a maintenance media. So we do this media switching technique itself. And the idea of doing this is to maintain the morphology of the cells before we basically put them back into the patient. How many cells can you get? Well, you can basically achieve about 240-fold expansion, so it's quite relatively possible to treat almost 90 or make 90 constructs of 9 millimeters with a cell count of almost 3,000 cells per eye to basically treat many more patients than we can do with standard cadaver tissue. So once you've expanded the cells, of course, you've got to actually deliver them inside the eye. And the two ways of doing that is either through a cell injection approach, where you simply inject the cells into the anterior chamber, and then the patient would then have to posture face down for about 3 hours, or you put them onto some form of carrier, as you can see in the basically video below. This is a video of 2 of our animal studies, preclinical studies done in Singapore. On the left-hand side, you'll see the cells that have been cultured in the lab, basically going to be transferred inside the eye on a basically carrier. The carrier here is a biological carrier, so it's just 50 micron tissue that are cut with a laser, and then they grew the cells on. On the right-hand side, you would basically see simple cell injection therapy itself. So once the model is created, you can see on the contact lens over there, this is an endothelial graft that's been with human cells, but have been cultured in the lab, and we put it onto a contact lens, and then we load it into a device. In this example over here, you can see the endoglide, which we use standardly for our DSEX and DMEC surgery. And on the right, you can see I've injected the cells inside the anterior chamber, and then this rabbit will then posture basically face down for basically 3 hours. On the left, the implantation of the surgery is very similar to what we see with ultra-thin DSEC or basically DMEC. Once it's basically pulled inside the eye, you simply just have to tamponade this with an air bubble. And this is very similar to routine ultra-thin DSEC, basically surgery. If you look at the outcomes over here on the left-hand side, you see the control group basically in the middle, and the tissue, what we call tissue engineered graft, or TEK, in the middle, and then cell injection on the right-hand side. On the right-hand side over here, you'll see the charts basically compared to normal controls, and the tissue engineered grafts over here in the lower bar, in the lower line over here. The cell injection therapy is in this one, and this is a comparison of tissue engineered graft and cell injection therapy. The key caveat for this itself is that if you do tissue engineered graft, you will strip off the Descemet's membrane. If we do cell injection therapy, we don't take off the Descemet's membrane, we leave the Descemet's membrane basically behind. So clinically now, at the moment, there are 4 clinical trials basically undergoing around the world, and I'll show you the differences between the clinical trials. 3 of the trials involve basically primary endothelial cells. So what I mean by that, they're using primary culture where the endothelial cells are expanded, and then they're basically given back to the patient. And this is the trial from Japan, Professor Kinishida's group, Emersil in Bascom Palmer, and our trial in basically Singapore. The differences between the trials is both the 2 above are cell injection therapy, and ours is on basically a carrier. The third study from which is published later on is a trial from Japan, from Tokyo, from Shimura's group, where they're using iPSC cells to basically resurface the back of the corneal endothelium itself. And I'll talk about the slight differences from this in a little bit more detail. This is a study from Professor Kinishida's group in 2018 showing the outcomes from basically simple cell injection therapy. You can see excellent outcomes up to 1 and 3 years. And these were the first patients that underwent this therapy, was simply injecting the cells inside the anterior chamber. And likewise, when you see a 5-year follow-up, they seem to maintain the visual acuity and also the endothelial cell count. A big caveat of this is if you look at some of the patients over here, these ones listed over here, these are patients who had a preclinical diagnosis of Fuchs, and if you look closely at the ones below over here at 6 months and at 24 months, you can see the guttae actually reappearing again on the surface over here, because remember with cell injection, you don't basically remove the guttata, you just basically try to remove the dead endothelial cells before you basically inject the cells inside the anterior chamber. More recently, they published a paper in JAMA Ophthalmology, and again, you can see that the guttae actually started to appear between 6 to 8 months following the cell injection phase itself. And in the long-term group, basically, you can see that they actually remain stable up to about 3 years, but the guttae seem to basically be coming back. And then they classified this small series into 3 groups, patients with what they call typical guttae and basically no guttae group. And it seems that the endothelial cell morphology there is better in the non-guttae group compared to basically the guttae group. Currently now, there are basically 3 clinical trials already completed in Japan. There is a clinical product that's called Visona. Basically, you can see this below over here. That's available in Japan. Currently, the cost is actually quite high, but it's subsidized by the Japanese government. And there are 2 phase 2 clinical trials that are going in El Salvador and 1 in the United States as well. Emersil is a slightly different technology. Again, cell injection, but the endothelial cells now are mixed with a magnetic nanoparticle, and then basically you inject the magnetic nanoparticle with the endothelial cells inside the eye, and then when the patient basically postures face down, there is a magnet to get the endothelial cells to stick basically onto the surface. The big difference between this technique and the technique I showed you previously is the endothelial cells are not removed. There's no basically surgical procedure. You simply just do the injection in the eye without actually doing any debridement or basically removal of any endothelial cells. Ellen basically presented some results at World Cornea Congress recently, and she showed that basically in their phase 1 study, there was about a 38% of patients that had a 15-letter improvement, and now they're doing phase 2 dosing studies basically going forward and recruiting up to 30 patients as well. The third basically study is using a tissue and engineered graft, and this is what we've been doing basically in Singapore. This is some of the first patients that underwent this surgery. So we basically engineered 3 grafts because we had an IRB restriction on this itself, all from basically one 38-year-old donor. These are the kind of grafts that basically you get. So typical cell count, you can get well over like 2,800, even above basically 3,000. And then you have a QC control or validation of these cells itself. So it's a human donor corneal stroma that we use, but we basically put the engineered cells that were engineered and expanded in the lab, and then we basically transferred this basically to 3 patients itself. This is just an example of basically one of the patients who underwent surgery. So it's a patient with obviously, generally for these we pick patients with poor prognostic eyes. They had this is the graft that came from the cell therapy facility. It's got a basically a silicone cannula. They put it onto a contact lens to make it easier for me to do the transfer of the tissue, and you can see there's a slightly yellowish color of the stromal tissue over here because it's been basically in cell culture media for a week and a half. So once I remove the silicone sponge that basically protects the graft from the surface, we transfer the donor tissue with on the contact lens, and then this is loaded up basically into the endoglide device as you do basically for normal corneal transplantation surgery. And then I'll just basically put some viscoelastic protection on the surface. The contact lens is basically removed from underneath it, so it's like acting as a bit of a support. And this is a 50 micron graft that was cut in the eye bank, but obviously in cell culture it will basically expand so it's slightly thicker when we do the loading. Just for the interest of time, I'll skip along the video a little bit faster as well. And what you can see is that I can't control the video. All right, but never mind. So basically we load up the graft to put it into the endoglide, and then this is basically put inside the eye, and the graft is basically inserted as you basically do for standard DSEC endothelium on the inside for protection. And then once it's basically inside the eye, then basically we tamponade this with air to basically stick this into position. So this is just like as we do with normal DSEC, and then all the sutures are basically then tied on the surface. Okay, so this is the outcomes that we basically can see. So this is pre-op on the left-hand side. This is day 1 post-op, 6 months post-op, and on OCT, all our grafts were basically attached onto the surface. And so far, we have data up to 6 months follow-up that we'll be publishing soon. The last technique I'll show you is basically iPSC cell generation. So this has been done in Japan. Again, what they will basically do, you'll see there is a removal of the basically endothelial cell layer itself, and then the cells are basically injected inside the eye. The iPSC cells are basically generated from a frozen stock and then differentiated into what they call endothelial-like cells itself. And in this one case that they basically published up to 12-month follow-up, it showed that there was no evidence of any teratoma formation inside the anterior chamber, and it certainly looked quite exciting. There is some functional recovery. You can see this is a patient with a previous penetrating capacity with poor visual acuity, but you can see according to the follow-up there was an improvement in visual acuity, and you can see from the central corneal thickness data there is an improvement in central corneal thickness as well. I'll just show you one last thing that we've been doing more recently, which is what we call SNECI therapy. So this is a non-cultured approach, so taking donor corneas with less than cell counts of 2,000, and then instead of basically throwing those corneas away or not using or using them for a dog, we're able to basically take off the endothelial cells using a very minimally invasive approach, stick them back into a syringe and inject them basically back inside the eye. And this has been something we've been working on the last 5 years. This is some of the animal studies, basically showed improvements in basic outcome, and we were able to get equivalent results with what we call simple non-cultured endothelial cell replacement, equivalent to what we're able to get with basically our culture techniques. And basically the cells are just delivered to the surgeon in a simple 1 ml syringe now, and we hope to be able to do first-in-man clinical trials in Singapore and a few other countries in the next basically year. So in conclusion, eye banking really and cell therapy really have to go hand in hand, and cell-based therapies offer exciting prospect to solve the global problem by de-skilling the surgery you can imagine to do a corneal transplant with simple injection of cells inside the endothelium. It reduces the long-term use of basically steroids, and it increases the access to more people for the small incision surgery. There are some issues, obviously, with any GMP manufacturing. You have to think of new sterility issues, intensive manpower to do the culturing, and of course regulatory approval, which will apply to all these basic therapies. Now we're looking at more of transportation of these cells itself, and it may we see that the eye banks are evolving into cell therapy units as opposed to their traditional corneal harvesting techniques. Thank you for your attention.
Thank you very much, Jyot. The next speaker is going to be Ashwin Agarwal, who's going to talk to us on pinhole pupiloplasty for the irregular corneas.
Thank you. So I'm going to talk about something new, something different, and how we can avoid a lot of the corneal-related irregular astigmatic issues that we all face in our practice. Just to start off, I do have financial interest with LSR, but it doesn't pertain to my talk, and okay, fair, here you go. So basically what we're trying to do is when we have irregular astigmatism, we're always trying to attack either the lenticular plane or the corneal plane. But let's look at a new paradigm where we're trying to attack the iris plane and trying to reduce or bring down the pupil size permanently, thereby reducing the chord mu length. What is the chord mu length? It is basically the visual axis and pupillary axis. The distance between that is the chord mu length, and that's what, when you reduce that length, it helps enhance the vision quality, enhance the vision crispness, and removes all the higher order abrasions from the cornea which is passing through. So it is based on certain principles which we call a Still-Crawford's effect. It's also the vignetting sign that we see in these cameras, who obviously have a lot of impact on this, and how the rods and cones behave in terms of light that's entering the eye. I'm not going to go into the principles too much, but the idea is also to give you investigations that you do in these cases are pentacam, retinoscopy, eye trace, which really helps, and I'll show you a few of those. The pinhole occluder, this really defines the customized pupil size that it should be for that particular patient, so it's customized for that patient. And you have the far, intermediate, near vision at different scotopic levels. Also the manifest refraction. This is on the left you see the pinhole occluder, which is basically what defines preoperatively. You place this in front of the patient's eye, and the patient then defines where, let's say 1.5 or 2 millimeters is the patient seeing the best quality of vision, which is what you will replicate on table on the table. On the middle you'll see the RMS value, which is the root mean square value of the higher order aberration. This is seen on the pentacam. You'll obviously have to go into the pentacam and see this. You can find this at the pentacam level. The normal value is 0.33. In this particular case it was 13.08. So what I'm trying to show here is any higher order aberration of more than 0.5, even more than, if you want to be a safe bet, more than 1, just go ahead and do a pinhole pupiloplasty. You'll be shocked with the results. That's what we're trying to ascertain over here. In an eye trace, you can see the level of astigmatism. I only want you to look at the circled images, the 1, 2, and 3. That is the millimeter of light entering the eye. So that's what we're trying to showcase over here. At 1 millimeter pupil, the astigmatism is dropped down. At 2 millimeter pupil, the astigmatism goes up, and 3 millimeter pupil, you have more and more as light entering the eye is directly proportional to the astigmatism of the eye. That's what we're trying to showcase over here. These are the instruments when you want to do this procedure. It's rather simple. It's actually just sutures is what you need, and your own skill. It's intracameral sutures, which we use, 9-0 or 10-0, whichever you have. The technique that is used is the single pass 4-throw pupiloplasty technique, which we all know is pretty simple, and it can be done repeatedly with less trauma, less inflammation, less iatrogenic issues that can come up in these pupiloplasty scenarios. But just you have to do them multiple times. That's the catch here. So here's case number 1. I'll show you some cases where this is a post-DALC patient where the astigmatism was off charts. Otherwise, I would have had to do a repeat PK in this patient. But no, we decided to go ahead and do a pinhole pupiloplasty, 4 of them, so that we can bring this pupil size down. Now, what happens is when you bring this pupil size down, it becomes a cat eye. So you need a vitrectomy system also, so that you can open up that pupil and make it circular to hit the first Purkinje image. And this is, guys, post-op day 1 without glasses. So this is post-op day 1. The post-DALC patient, which I would have otherwise had to do a complete PK. And that's what we try to avoid in this case. This is a second case, which is a 20-year-old back, LASIK done. Look at the striae. You can see the striae, and you can imagine what the patient must be going through on a daily basis, because the pupil size is continuously changing. And what we're trying to do is, this is the worst case scenario cases, guys. This is not your run-of-the-mill everyday kind of case. So these patients are very, very unhappy. They have been for 20 years suffering with that striae, and what we're trying to do is don't touch the cornea, because we don't know the result of how that healing process will be. Here we are giving a very sure form of success rate, but you got to get the technique where you close the pupil size down and then open it up, because it will become cat eye. You open it up and make it a circular 1.5 or 2 millimeter. The visual, what I tried to show in the last images of this video was you can even get a really good field of vision. It does not hamper the field of vision. I know a lot of questions will be asked on that, and I'll come to my most obvious question, which we'll come to. This is a post-RK patient. Obviously, I've removed the conjunctiva so that we can avoid any incision expansion because of the RK wound. Obviously, in these cases are again terrible corneas, because you have a very irregular astigmatism in these cases. The easiest and the format we've seen in these cases is to do a pinhole pupilloplasty, and it removes the issue in these cases. Just in interest of time, I'm going to show you. This is 2 weeks post-op for same patient, and this is the fundus image after the pupilloplasty. That's what I wanted to tell you. Obviously, there's one question now everybody's in the room will ask me is, how do you see the retina? The retina is, I just showed you the last image, that was Mirante. I use Mirante. I have no financial interest with them, but I use the Mirante, and that's one of the techniques that you can use to remove irregular astigmatism from your, use it in your practice. Thank you so much.
Thank you, Ashwin. I have one more question. PCO, I saw in one case you had some PCO and you do the pupilloplasty. So do you take care of the posterior capsule first?
Yeah,
before you do the pupilloplasty?
Yeah.
You
have
so
to
you
do
open the
PCO.
posterior capsule?
Yes.
Yeah, okay, yeah, that makes sense.
Absolutely. Next up, we're going to have Professor Amar talk to us about complications and cases. Challenging.
Thank you very much, Dr. Ashwin. Such a pleasure to have Eric also here with us. So let's talk on predestined endothelial keratoplasty. So this is PDEC, which we first started with Professor Harminder Dua. You can see you're looking at the endothelium on the top, okay? I've turned it upside down. So what you are seeing on the top is the endothelium. Remember that. From the sclera, take a 30-gauge needle, go inside, and you see I've created a bubble. Now look at this bubble. It does not go to the periphery. This is a type 1 bubble. So where is the air? You have the endothelium, you have got the desmase, you've got the Dua's layer, and then the bubble, and then the remaining structure, which is stroma. If it went to the periphery, it's a type 2 bubble. That means basically you have endothelium, desmase, then the bubble, and then the Dua's and the stroma. So we are not interested in creating the DMEC bubble. We are trying to create the PDEC bubble. Enter into this, inject trypan blue now, so that stains everything, dissect it, and now you have the PDEC graft ready. If you want, another way to do it is, you made the bubble, cut it a little bit, flip it, you can make a hole in the center, now turn it upside down, so if you want to do a marking, S-shaped mark on the graft, you can do that also. Both ways are available. This was a case referred by a top retina surgeon, Dr. Natarajan, one-eyed patient. You see, there was silicone oil there. So I've just taken off the silicone oil. Now you can see that pupil is bad. So I prefer to do a single pass, 4th-row pupiloplasty the way Ashwin showed. You can see the same animation. Pass it from one end, bring it out, remember the number 4, and pull on both ends, and that is game, set, and match. So here you see, after I've done the 4th-row pupiloplasty, I've injected the graft. All you need to do is, you can see the trocar AC maintainer. I've got air infusion continuously. Look at the same patient, pre-op, post-op 3 months, 618, and you can see the fellow eye was no PL. So now let's move on to other cases also, which I thought I'll show you. We also use infant donors. That means the youngest we have used is a 9-month-old donor. Look at this patient, scarred cornea, PDEC on a failed DSEC with photoreoplasty post-op, 1 month, vision was 6/9. Look at another patient. This patient had an IOL there. You can see an anterior chamber IOL. We explanted it, did vitrectomy, glued IOL, photoreoplasty, PDEC. Look at the vision, 9-month post-op, 20/20 vision. Okay. Now look at another patient, one-eyed patient, failed penetrating keratoplasty. Look at the anterior segment OCT below. And now you will understand, post-operatively, we have not removed the cornea. All we did is did a PDEC on the failed graft and make the patient all right. So this is PDEC with single pass, 4th row, pupilloplasty. What about reverse 4th row? I showed you single pass. In reverse 4th row, we are going from behind the iris. So what happens in this case is, and I have to give credit to Dr. Priya Narang for this also. So you see here, the knot or the tail goes behind the iris. The advantage in this is, suppose you're having a PDEC graft or any graft, the tail will not hit it. This was another case who had referred to me by Dr. Natarajan. This patient had been operated 6 times, see the scarred cornea, had gone in for a routine cataract surgery only, and had got complicated elsewhere. Now look at the scar, it's so bad. So I'm doing a vitrectomy. You can see the trocar AC maintainer there. I couldn't see clearly, so I'm taking off the Descemet's endothelium complex there, and you can see that fibrotic tissue is stuck to the iris. So one hand is holding the fibrotic tissue, other hand is cutting with a scissor. I'm cutting the whole structure there, removing it off en bloc. Now you see inside, as I see, remove that structure, now I'm seeing there's something shining inside. And you can see that's a subluxed IOL. So I catch it anywhere. Luckily for me, it was a 3-piece IOL. Do a handshake technique, and I made my flaps there. All I'm going to do is transfer it from one hand to the other. Ladies and gentlemen, if you are not seeing, please understand, even I'm not seeing. Okay? That's that bad, that cornea. So first haptic is out. Now I do my vitrectomy, clear up the remaining mess. Now I try to catch the haptic anywhere. You see, I've caught it somewhere. Doesn't matter where. All you do is transfer the haptic from one hand to the other so that you can now catch the tip of the haptic. Once that is caught, externalize. So far, so good. Once that's done, now my next step is to tuck these haptics inside. So I take a 26 gauge needle, tuck this into the Chariot's pocket. Once it's there, this great system by Gabor Chariot from Germany, tuck it into the Chariot's pocket. Now I do the photoreoplasty. Now remember one thing. In this, I'm also making a closed angle open. I'm also doing a pinhole so that any astigmatism gets neutralized permanently in this patient, because whatever the astigmatism, it does not matter. Whatever the HOA, it does not matter if you made a pinhole. Now you can see I'm doing the photoreoplasty, and the advantage in this is you can do as many times as you want. And it's a very simple technique. If someone has not done it, please, you can start on this. Remember the number 4, pull on either end, and that completes it. Once I've done this, you will see me now completing that pinhole pupil there. My Purkinje image is pretty okay there. Now all I do is, remember that I have to take off the remaining Descemet's endothelial complex. Most of it was already removed by me before itself, but anything remaining, I'm just checking it. I've got continuous air infusion from the trocar AC maintainer. Create my PDEC graft just like I talked to you before. Once my PDEC graft is ready, I take it, inject it inside. The question comes now, how did this patient do? So why am I doing PDEC? Why am I not doing DSEX or DMEX? 1, I use young donors. 2, my manipulation is easy. 3rd is I do not get detachments, rebubblings. My rebubbling rate is about 3% only we have. Whereas if you see DMEC in books or literature, it's about 25 to 30% by people. So you can see the same patient pre-op which I showed you, and look at the patient, same case, 45 days post-op. So now, I thought I'd show you something more here. Look at this patient now. This patient came to me from Philippines. It was so bad, I couldn't see anything inside anyway. So what I did was, I didn't know what to do. So I took an endolmeter from outside also, I couldn't see, but I could see something moving around that eye, inside. So I make my scleral tunnel, but still I'm not seeing with an endolmeter from outside. So what I said was, I took an endolmeter inside the eye. And now you can see that iris claw IOL there. Half is stuck to the iris, half is sinking. Using the endolmeter inside with one hand and a forceps in the other hand, I catch it and I explant that IOL. Once that's out, I now go in with the glued IOL technique, and you can see me doing that just now. Once that is done, my next step is to do, obviously, I need to make that pupil small. So I'm going to do the fourth row pupiloplasty. I already have a large incision, so I just used to implant it like a non-foldable IOL, tuck the haptics inside. Once that's done, now I start my fourth row pupiloplasty. But look how friable that iris is. Wherever I touch, it starts tearing. This portion is done. Now when I start at the other side, I'm breaking the peripheral anterior synechiae. I'm trying to do it, but I just am not able to continue it because of the visualization problem. So I thought, let me stop for some time. Let me try to remove this bad endothelium desmase complex. You see how bad that desmase endothelial complex is? And most of this fibrotic tissue is also stuck to the iris, as you can see there, see? So you would hold it with one hand. With the other hand, I'm cutting it with a vitrectomy probe. Remember, this patient has come all the way from Philippines to me. I have only one chance. Obviously, he cannot go and come back. A top ophthalmologist from there had referred this case to me. Now I continue to do this surgery. You can see my Purkinje image is bank center, but there's an iridolisis there. So I use the trocar-assisted iridolisis which we published. Basically, it fixed a trocar right opposite the iridolisis. Double arm Prolene needle. You see, pass one, pass other, pull. Once you pull, you tie, and you clear up the iridolisis. So that's the way to handle iridolisis. I'm doing that on one side. Once the repair is done, now the next step which I move is to create my bubble there. Once I do that, again I have got my graft ready, inject it inside, and then let's see how this patient behaved. So you can see that's the graft there. After injecting the graft there, you can see now, I don't use a marker, but you can if you want. We use the endolimiter, which gives me a very good effect there. So fix the glue. Question comes, how did this patient behave? Look at the patient post-op day 4, and look at the same patient post-op 2 weeks, vision improved to 6/12. And look at the pre-op, how bad it is, the cornea. I couldn't see anything. And that's the patient post-op. Look at this picture here, infective keratitis. So bad the cornea was, they did a therapeutic penetrating keratoplasty. Wait for 4 months. Don't worry, it will fail. Don't worry, let it fail. Okay, we published this in the cornea also. Once it has failed, now what I'm going to do is I'm going to do a phaco in this. So you have a very bad corneal ulcer, not manageable by medical treatment. You have done a penetrating keratoplasty. Wait for some time. Let it fail. Now after 4 months, I've done the phaco. I'm going to do the fourth row pupiloplasty. Once my fourth row pupiloplasty is done, then you see me now. I'm making the pupil smaller and smaller. Now I know this patient has got a huge PK. Remember, there will be astigmatism. I make it pinhole, 0 astigmatism. I don't care what the astigmatism, whether it is 10, 20, 5, 6, doesn't matter to me. Either way, I've neutralized it. Once that's done, next step for me is to do the PDEC on it. Again, you can see we created the bubble there, remove the desmase endothelial complex, and once you have done that, you can see I'm injecting this graft there. Once that is done, you'll see me in a second seeing this patient post-operatively, how this patient looks. Look at that infective keratitis, post-therapeutic PK, and you can see now 3 months post-op, how the patient's vision is 6/6. If I can have just time for one more presentation, which I'd like to just show on. This was a one-eyed patient who had come to me. Now, this was the only eye of this patient, okay? So let's see this case also. This was the patient. Look at this, dropped IOL, bullous keratopathy with hazy cornea, and there is a huge ciliary staphyloma, okay? The problem here now is, what do I do? I can't do anything on the top. If I cut there, I'm gone. So I make my flaps, and they were not 180 degrees, so I make it better to make the flaps 180 degrees. Now, this patient had a one-piece, non-foldable IOL inside. Remember, this is the only eye of the patient. So I go ahead and do my vitrectomy, and the technique we use is the ECAL, which was started by Ashwin, basically, and through that hazy cornea, you can see that single piece, non-foldable IOL lying inside. We use the cannula, extrusion cannula assisted levitation after vitrectomy, using the suction, pull it up, shift to a glued IOL forceps. So I've done that. Remember, this is a one-piece, non-foldable IOL. If I'm not careful, it will break. And if it breaks, I'm gone because I don't know how to explant it. There's no space for me. That huge ciliary staphyloma is my problem. So now, I've caught the haptic, and you can see that's the PMMA haptic. Be careful when you tuck, because you can't flex and tuck. Withdraw and tuck. Now once that is done, now I move into the surgery of, again I do the same process which I've been talking to you about. Do the photoplasty, make that pupil a bit smaller, break the sine K, convert the, simple what I'm trying to tell you is to convert, the basic idea here is to convert the closed angle to open angle. Once everything is done, and I made the pupil pretty good as much as possible, remember that huge ciliary staphyloма is there. Now all I need to do is take off my endothelium desmase complex there and implant my PDEC graft. So here you can see I'm just continuing to do the pupiloplasty. Once that is on track there, and I've closed every bit as much as I can, I understand the problem will be there in such cases. I go ahead and do my vitrectomy probe to make my pupil bank centered and round exactly the way I want it to be. And you can see that Purkinje image P1 is bank centered. So now let's see how the case does at the end. Once everything is done there and my pupil is well centered properly, I'll just go in, take out my desmase complex. A little bit of iridectomy area is still damaged there. I would like to close it because that air will go back otherwise. And then I'll have a problem of my PDEC graft, so I don't want to leave anything behind unnecessarily. I'd like to close all these small defects also, so that no air goes posteriorly. So the advantage, why do we not get a rebubbling is basically this. In the PDEC graft, remember, you're having duas, desmase, and endothelium. The duas and the desmase are fused. They cannot detach. So you are sticking dua to a dua. So there are two duas layers in PDEC graft. And that is why you don't get rebubbling present in PDEC graft. Whereas in a DMEC graft, you're sticking the duas to the desmase where there is a space or a gap present, which can obviously detach and which produces the bubbling. So the final picture, and then we'll move to the next speaker here, is this. I'm injecting the graft. Remember once again, ladies and gentlemen, this is the only eye of this patient. It was a young patient. So after everything is done, let's see how this patient behaved at the end of the day. This is the patient post-op day 1. And you can see now 1 month post-op, ladies and gentlemen, we did dropped IOL, bullous keratopathy, ciliary staphyloma, we did the ECAL technique, did the gluteal, did the photoplasty, did the pinhole pupiloplasty, and ended with PDEC. Thank you very much.
Thank you, Professor Amar. Next up, we have Eric Mertens. Obviously, while he's setting up, I'll ask a question. Are there any cases you say no to? I will not do this case.
If by chance it is very bad, by and large, I tell people it's really badly scarred. By and large, I would manage them with these. Many cases which you would go for Boston keratopathy, we do the PDEC. I will say do a PK, then it's much better off. But even in PK, please understand, just doing a PK in a pseudophakic eye makes no sense. Make a pinhole, then only the patient will be able to see clearly without glasses.
Awesome. Thank you so much. And next up, we have Eric Mertens, who's going to talk to us about a very important topic. How do I introduce trifocals in my practice? And obviously, you're going to give your own perspective on this. Amazing.
Thank you, Ashwin, and thanks for the organizers for inviting me. I'm very thrilled to be in India for the 3rd time, and I was submerged in Indian culture a couple of days, and I must say I like it very much. But back to my topic, introducing trifocals in the practice is not as easy as you could think. So I will try to explain to you how I did it and how you can do it yourself, introducing it successful into your practice. This is my financial disclosure. So first of all, what is very important is the power of the patient experience, because this will make you stand out to your competitors. So this is a Harvard Business Review, which was published a couple of years ago. And it was a publication about how to rate your customer experience with your company. So there were 5 levels. Level 1 is unacceptable, up to level 5, which is excellent. And in this review, they asked the CEOs of a company what they thought their customers were rating their company. And then it was asked to the customers by themselves. So look what happened, look what they found out. So 80% of the CEOs, they thought that their companies were rated as excellent, so 5 out of 5. But in reality, how many customers do you think were rating also an excellent customer service, it was only 8%. So there is a big gap between what you think your customers or your patient think about your company or your eye clinic and what in reality is perceived as excellent is not the same as you perceive it. So customer satisfaction is not the same thing as customer experience. So there are different levels and different things you have to understand. So customer service is understanding the need of your customers and providing adequate advice and assistance. Then you have customer satisfaction. So patients come in for trifocal IOL implantation, so full range of focus implantation, and they're very satisfied with their result. But it does not mean that the customer experience is at the same level, because customer experience means how do customers, patients perceive the whole experience in your practice, from the ringing your clinic for an appointment, dealing with the reception desk, and so on and so on. So customer satisfaction is not the same as customer experience. Because in medicine, patients do not judge the doctor by the skills and his instruments, because all patients think you are a very good doctor, because otherwise they do not come to you. So first of all, they all think that you will deliver a very good results, but they have no way of evaluating these factors. Instead, they judge you based on the perception of quality using other attributes as proxies. So when you're introducing full range of focus, so these advanced IOLs to get rid of glasses, you have to change your practice mindset from pathology to performance. So what does that mean? And words matter when talking to patients. Words matter because they are not accustomed to what we use in medicine as our terminology. So instead, we perform lens replacement surgery, but we do it not only for cataract, we do it for dysfunctional lens syndrome, we do it for refractive error, we do it for lens instability, for IOL-related problems, of combinations of all of the above. So when a patient enters my practice, what do we do first? The first step is realizing that each patient is unique. We have to listen to them, we have to listen to their lifestyle, what do they want, what is their work, what are their hobbies, what we have to deal with their frustrations and their motivations regarding their vision. So you see here three magnificent ladies, and each of these women, they will having refractive surgery. One of them just happens to have cataracts. So we don't ask those patients, what's the matter with you? We ask them, what matters to you? So it's a completely different communication style, which resonates very, very good with your patients. What is the second step? Perform all examinations at the same time, so at the same visit, before giving advice. Meaning, what we do a lens replacement workup, we do all of those measurements, biometry, ocular surface workup, and so on. So step by step, you evaluate the whole eye at once. Step 3 is you talked with the patient about their lifestyle, what their frustrations are, what they want to achieve after the surgery, and then you decide what is medically acceptable, which lens are you going to implant. This is the third step, and what is very important, that when patients come into your practice, that you downsell, not upsell. What does that mean? In my practice, all patients are candidates for trifocal IOL implantation until proven otherwise. So we have one fixed price for this premium IOL category, and regardless of when they need a dry eye evaluation or dry eye treatments, we even supply them with omega-3 supplements if necessary, free of charge. Unless it's proven otherwise, we downsell to EDOF or monofocal plus lenses. For instance, when they have advanced glaucoma or when they have a macular pucker or so on, we first refer them to our glaucoma specialist or our retina specialist, and we ask them for advice before we giving an advice of the IOL to implant it. So this is very important, downsell, not upsell. Because when you upsell, you advertise with low prices, they come in your practice, they say, oh, you need to have a dry eye treatment, oh, it costs you that amount of money, or oh, you need an astigmatism correction, it's an extra charge, oh, you want to get rid of glass, an extra charge. The patients, and imagine when you go for services somewhere else, and they're trying to sell you more and more, so a higher price, you feel uncomfortable. Our patients also feel uncomfortable when you try to upsell procedures instead of downselling. Once you have established all those 3 steps, you go for the step 4, which is you make a specific recommendation for the outcome. So one specific recommendation. The more possibilities you give your patients, the more they start to doubt, and the less likely they will book you for the surgery. So just one recommendation, what fits them the best. So what are the key takeaways of my message here? So that your perspective is not the patient's perspective. As I showed, 80% of the CEOs, they thought they were excellent, 80% of their customers thought they were excellent. So good patient satisfaction is not the same as a good patient experience. And this is all about the patients. It's not about you. So listen to your patients, know what they want, know what their hobbies are and the expectation after surgery. Because they know themselves better than, let me get rid of this one, better than anyone else. Don't give options between lenses, only one option after listening to the patient, after doing all the refractive workout. And you have to be the guide. You have to guide them by the hand so they feel just treated well by you, so to have a personal best vision solution outcomes. Now, with what kind of strategy do we treat our patients to correct them with a full range of vision IOL and to get rid of glasses? So I want to introduce a new strategy with full range of vision. And for this, I use the Vivi Next Geometric Trifocal IOL family for a couple of reasons. So this is based on the Vivinex platform, which is a proven platform with monofocal IOLs. It is a very unique set of lenses. It is not apodized. It has a 3.5 diopter near add and a 1.75 intermediate add, and there's also a toric option available. It is fully proloaded with a multi-cert injector. You have different options with that injector. You can have a push option or a screw option to your discretion. And also the nozzle, you can extend the nozzle so you can deliver the IOL into the bag, or you can retract so you have a very small nozzle into the incision of the cornea. So for those surgeons who do not want to enter the anterior chamber further than that. Now, there are 2 lenses in that family. We have the Geometric and the Geometric Plus. Very important to know that the distribution is the same across intermediate, distance, and near. Only the light distribution is a little bit different. So the Geometric brings light, the energy distribution for distance is more than for intermediate and near. And the Geometric Plus gives more light distribution to the near focus. So here you can see this when you have the Vivinet Geometric on the top here. This excellent far vision when you implant it in both eyes. It gives very good intermediate and good near vision. The Geometric Plus with the light distribution more towards near gives an excellent near vision with a good intermediate and a very good distance vision. So this is the multi-cert injector again. So my nurse is preparing it on your right-hand side. So this is, in my opinion, the best preloaded combination ever. The lens is delivered in a very safe way and in a controlled way. As you can see, I guide it with my left hand with the second instrument, injecting it into the eye. And as you can see, the haptics are delivered slowly into the bag. So, and what about the pairing strategy? So I talked about the Geometric in both eyes, I talked about Geometric Plus in both eyes, but what you do in most cases is I pair those 2 lenses. Why do I do it? because while pairing it, it gives me not only excellent vision for distance, but also for intermediate and near. So I will show you here the distribution of the light. I told you here the light distribution is different for distance. More light goes in the geometric IOL for distance and less light for near. And on the contrast, the geometric plus gives a higher energy distribution for near than for far. So what does this give us in real life? And this is the NINO study. This was done by Professor Kaimak in Düsseldorf, and this was published in Clinical Ophthalmology last year. By combining Vivinex geometric in both eyes, it gave excellent distance vision, but less near vision. By giving both eyes the Vivinex geometric plus, it delivered very good near, but less far vision and less intermediate. And what he found out, that 84% of eyes giving the pairing, the geometric and geometric plus in both eyes, that they were within half a diopter and giving an excellent result. Here is the binocular defocus curve 4 to 6 months postoperatively. As you can see, by combining those lenses, it's excellent distance vision, as good as both eyes, the geometric. The intermediate, when you combine the geometric plus with geometric, it gives a very good intermediate, a little bit less than both eyes geometric, but still very good. And for near, it gives the same as the geometric plus in both eyes. Here is the subjective patient feedback on spectacle usage. You can see by pairing the geometric with the geometric plus, it gives excellent results for distant, intermediate, and near. Why is this different than mix and match? Because these lenses, they have the same refractive index, so there is no difference in between the two eyes when you mix and match IOLs. It has the same chromatic aberration. It has the same haptics, so it has the same behavior in the capsular bag than when doing mix and match and using different lenses. So the NINO studies concludes that the geometric and the geometric plus trifocals may be used bilaterally or in paired contralateral fashion to provide effective correction of presbyopia. Binocular visual acuity is excellent at all distances. In these 3 study groups, the mean values were above 0.15 logMAR, from half a diopter to minus 3.5 diopter of defocus. And the concept of pairing light distribution profiles and add powers ensures a continuous range of vision from far to near. Pairing those 2 lenses is the most balanced combination for the highest spectacle independence at all distances. And on conclusion, we can say that every patient in my practice is a candidate for full range of vision IOLs until proven otherwise. So downsell, not upsell, if you want to be successful in this category. Concentrate on who the practice serves and why, and not talk about sickness or disease, but about performance. Prepare the eye for high performance IOLs. What do I mean by that? So prepare the surface of the cornea to make sure that there is no dry eye, because you will end up with wrong IOL calculation, and you have to be within half a diopter of sphere and half a diopter of astigmatism correction after surgery. The geometric pairing combines two identical profiles and is much more favorable than doing a mix and match procedure. There's no need to identify the dominant eye. You can put the geometric plus in the dominant eye or the geometric. The results are the same, as also proven by the NINO study. And it gives, because the center of this lens has a diffractive profile, the rest is a refractive profile. So in dim light conditions, and the pupil dilates, there are less dysphotopsia and a good contrast sensitivity. So I thank you very much for your kind attention.
Awesome. Thank you, Eric. I have one question, and we'll call it a close because I think we have a next session after this. But the question is, in trifocal torics, how important is, there's always a margin of error that you can go off axis 5-10 degrees if it's non-trifocal. But in a trifocal toric, how does that play a difference? Have you had...
You mean,
if it goes off axis by 5-7 degrees, does
Yes.
it make a difference?
Yes, it makes a big difference because every 3 degrees you lose 10% of your astigmatism correction. So meaning when you have 10 degrees of axis, you lose 30%. So it's very important that you align these lenses perfectly in the good axis. That's another importance of treating dry eye before surgery, because when you're doing the measurement with your biometer or with a topography device or an anterior segment OCT, you will end up with different axes. And when you do not treat and optimize your ocular surface, you will think your toric alignment will be in the right axis, but it will be off axis, and you will end up with worse results.
And any tips for how do you get centration and how do you get toric reduction and stability?
Well, the thing is that you have to, or you mark the horizontal axis. Me in my practice, I always use a femtosecond laser to mark in the cornea their exact axis, and on top of that, my microscope is equipped with a toric alignment system, so I have 2 systems to align the IOL in the right axis. On top of that, it's very important to remove all the viscoelastic from behind the IOL, so it sticks to the posterior capsule, and it remains there as well. And of course, you need to use a proven toric IOL platform like the Vivinex, which is proven for many years.
Awesome. Thank you so much. And we're going to call a close for this session, but thank you, Eric. This was also the keynote address, so big round of applause for Eric. Thank you so much, Eric.